What are our relapsed options? And I think the real message is that now that lenalidomide-based therapy in the upfront setting has become a standard of care, and that induction remission regimens have a lenalidomide backbone with a proteasome inhibitor, be it Bortezomib, carfilzomib, ixazomib, all of these combinations up front mean that we have to then have best regimens for relapse. And Dr. Wiesel set it up beautifully when she said, that if you looked at recent publications in real-world experience, once patients relapse, in fact, the number of patients who get treated successfully is surprisingly low. So that begs the question, do we have real-world regimens that are convenient, effective, and practical for providers to offer patients? And I think that session was really designed to sort of frame that for those in the audience who care for patients and have to look at a patient with relapse disease and say, what's the best option? So my job was to really review the current randomized trials that are available, and in particular focus on those studies in which we've evaluated the role of regimens after lenalidomide fails a patient. And I think that's the area where, frankly, the randomized trial landscape is relatively thin. And in fact, the best and first study to evaluate that space, in my opinion, is the OPTIMISMM trial, which was a privilege to present on behalf of my co-investigators, which basically evaluated a 3-drug triplet compared to a standard of care, a doublet, in patients in whom they'd all been exposed to lenalidomide, and most importantly, 70% of them were lenalidomide-refractory. Now, the study compared Pomalidomide, Bortezomib, and Dexamethasone to Bortezomib and Dexamethasone. Obviously, patients could not be Bortezomib refractory because that would have lacked equipoise going into the study for our patients. But they could have been exposed to Bortezomib, or they could be on maintenance. Similarly, they had to be exposed to lenalidomide, and they could be lenalidomide refractory because we know that pomalidomide can overcome lenalidomide resistance. So putting it together, after comprehensive phase 1 and 2 studies had demonstrated the safety and efficacy of the pomalidomide, Bortezomib, and Dexamethasone combination, we evaluated approximately 600 patients either receiving PVD or VD. They had to have had 1 to 3 prior lines of therapy, and very importantly, each arm was continuous. It wasn't fixed duration. And that's very important because we've learned as a paradigm that continuous therapy in myeloma is also a new standard of care, be it in maintenance up front or in the relapse setting. And I think this trial also helped validate that, because the outcomes for both arms were good compared to some of the other trials we've seen over the years, and at the same time, what we saw was a striking difference in favor of the 3-drug combination. By intent to treat for the whole population with an early look, the progression-free survival advantage was approximately 4 months in favor of the 3-drug combination. But if you drill down on the first relapse group, in other words, those patients in whom their first line of therapy had failed them, that group of patients got particular benefit from the 3-drug platform, and in fact a median gain of around 10 months with a hazard ratio of 0.5. So that's really quite compelling, and that actually surprised us. That was bigger than we expected, and we saw a response rate in that group of patients of 90%, which reflected the activity of the triplet in that setting. Now, in pre-specified subgroups, we looked at high risk, age, renal dysfunction, a variety of factors, and in every single subgroup the 3-drug combination was better. And so with that in mind, we think this now offers a new standard of care. And of course, tolerability becomes another issue, and in that context, tolerability was remarkably, I think, favorable for the 3-drug platform because there were no unexpected safety signals, and generally speaking, the side effect profile was manageable. And we've got more information coming from this trial, including correlative science, MRD, and other important surrogates. But I would say that another striking benefit that we saw was that time to next therapy, which is becoming an important real-world consideration, was about a year longer for those patients who were on the 3 drugs versus the 2 drugs. So that again is another important marker for both clinicians and for patients in saying, look, this regimen offers an excellent platform. And the question is, where do we go from here? What does this platform offer? Well, I think as we see monoclonal antibodies coming into this space and making a real difference as well, the obvious conclusion is that we may have a 3-drug platform to which we add an antibody that may be another new exciting advance for our patients. So overall, a very promising future in that regard.